Public Trust, Dr. Jessica Schmidt, who's the Global Health Division Chief at University of Wisconsin-Madison, and Dr. Grace Wanjiku, who is also from the Division of Global Health at Brown University. For today, we have 4 questions for our panelists, and then hopefully we'll have some time for Q&A at the end to take any other questions from the audience. But I thought we could start off with each speaker giving just a 5 to 10 minute introduction about themselves and their work within global health and ultrasound. Tom, if you want to start, and then after that we can dive into the questions we have for the panel.
Happy to start. I just thought to put a few slides together, if that's okay, to share a few slides. I'll do my best to be in 10 minutes.
That's no problem at all. And you should be able to share your slides at the bottom of the screen.
Should be doing. Are you seeing my slides, or
Yes.
you see something about my slides? And
We can.
now maybe you see it in present. Continue to share. Yeah, share.
Looks perfect.
Okay. Yeah, thank you for having me and for inviting me to this session. My name is Tom Heller. For those, for those who do not know me, like Denise, like she said, I'm an internal medicine and infectious disease German physician trained originally in Germany, and maybe we can talk later about that Germany has a little bit of a different approach to ultrasound since ever. That has nothing to do with me. But my work was mainly, or the work that I want to talk about was mainly done in sub-Saharan Africa. I worked over 9 years mainly in Malawi and in South Africa. And of course, there is a lot of it's very resource limited in a way, in the sense that we don't have a lot of diagnostic tools, and that makes ultrasound even more important. But it also gives, I think, some ideas, or at least it gives my views on what is sensible to train and what is maybe, and how it is sensible to train. Um, yeah, that's maybe about me. And now I just want to give a few slides because because I think it is makes it maybe a bit clearer. So what I don't know if you have heard about the FASH scan. So that is the fast scan, I assume, for a given. But then we in 2009 or 2009 or something, we were working in, my wife and I were working in South Africa, and then we saw a lot of patients with HIV-associated TB. And then, because we couldn't call it focused assessment for sonography for TB because T was already taken, so we put it HIV-associated TB, and then it was FASH, which made it quite fashionable. And then the name stuck. And basically, it is the FAST protocol just reinterpreted, because effusions can also be signs of TB in a different set of patients, of course, not in trauma victims necessarily. And then we added upper abdominal lymph nodes in the upper epigastric view, and we added splenic microabscesses. And that are both signs which we felt, and which we still feel are quite suggestive of TB. And in many places where you don't have much more, you would say, hey, this is enough to start TB treatment. But that's not necessarily what I want to talk about today. I want to talk a little bit beyond. I mean, obviously, I think I don't need to tell you why we think that POCUS is attractive for resource-limited settings. I mean, we are all using ultrasound on a daily basis, I guess, and that makes it for us like, oh, this is a great tool. There's no radiation, no side effects, real-time images, increases safety, is so good that it must be good for everybody. And then additionally, technology has made great strides, as you can see on this collection. And of course, you know that again better than I. This ever cheaper getting tools, like, I don't know how they are all called, the handhelds and whatnot. And now they get even smarter. There's algorithms involving AI. So I think that gives the idea to everybody who is excited about ultrasound to say, hey, we should transfer this knowledge, or we should transfer this technology to somewhere where resources are scarce. Now, I just want to make a disclaimer before it's the first time that I really want to make the disclaimer, because usually I just put this slide because I have to. But I did not receive any benefits from any ultrasound company yet. I hope they one day come and bribe me to be rich. And anyway, likely not. But I have to say that Lighthouse Clinic Malawi received two donated ultrasound machines from Mindray in 2024. And so I show some slides from Mindray screens, which is yeah, which is not because we have them. Um, Now, what is different about focus and resource limited settings? And I think that is an important point if we go to teach, because I mean, what I think we need to understand is that the epidemiology is different. So we have other diseases. So HIV, tuberculosis, and the FASH protocol, which I just outlined to you. If you use that in any emergency room in the States, it would be completely useless, because the chance of meeting somebody who has HIV and TB, disseminated TB, is simply too remote. That is logic, and none of you would probably say, hey, we should teach FASH in our courses here in the States. On the other hand, the opposite is true as well. For example, appendicitis is really very rare in African settings. I must admit that I have hardly seen, no, I don't even remember if I've seen a single case of appendicitis in all the years that I worked there. Whereas on the other hand, typhoid fever, which is not in the States, might be more frequent there. And also other things like the right upper quadrant pain triggers we should do I don't know how you call this, a gallbladder scan, right? Yeah, for me, I would say let's do an HCC scan, because it's simply much more likely that we find that. Additionally, what is important for the discussion maybe later is to remember that the setting is also different, because people rely very, very heavily on this ultrasound, because there is simply no other tests available. So, and if we in our setting say, okay, we do an ultrasound and we find something, okay, then let's do a CT scan to put it into, to get it more solid. That option is usually not available. So, and similar is it for lab tests, which cannot be used to confirm what we decide. So very often, whatever you decide on your ultrasound is the last frontier. After that, it's only, yeah, God, or I don't know, whoever. It's really very and that makes the decision relatively I would say very I don't know what's the right word. They carry weight, because people believe in images, right? If you say, oh, I've seen it on ultrasound, then they will say, oh, it's on ultrasound, so it must be correct. And that is brings a lot of responsibility. The best example for me, which I talking about teaching ultrasound and looking at typical American or European emergency curricula, the AAA scan is for me an interesting example, because it's nice, it's simple, and it's nice to teach. But number one, I have hardly ever seen an aortic aneurysm in Africa. I mean, I've seen few thoracic ones, which were due to syphilis. The next thing is I have never seen, or it's very, very rare that you have a vascular surgeon. So you're doing a scan and then you find something and then you say, well, yo, that's it. So that doesn't make very much sense. So I think that's, for example, one of the topics which if I would put together a curriculum, would be the first that I cut out, because it has hardly any impact in my opinion. Good. Now, what I find when you look at what to teach, and that is in the end, that's what you have to do when you go to a new setting, a new cultural medical cultural setting, is which conditions are relevant, which conditions are necessary to teach. And number one is to look at prevalence. Is this what I do frequent? If it's not frequent, it will likely be forgotten by the time you find it the first time. If I find it, can I change my treatment? Because if I can't change my treatment, then no need to. I mean, it's nice. It's l'art pour l'art. You can find something and you can get nice pictures, but it doesn't change your management. And then most likely clinicians will say, I can spend my time with other things better. And then the last one is, of course, and that's probably true in all settings across, that the sonographic times need to be reasonably easy to be teachable in a few days or hours that we have. So I mean that, but that is uniform. That is nothing special. But the prevalence and the impact is something that we have to consider. So, and in a way, people tend to say, teaching ultrasound, I mean, it can't harm. And I don't want to say that it can harm terribly much, but there is, of course, there is also a little bit of an opportunity cost, because I mean, if I come and say, oh, I want to teach you ultrasound, I mean, everybody wants to come because it's kind of nice to be taught, but it takes people away from doing other things which might be more sensible in that way. So it is something to consider, what is relevant and why do I teach that? So we use this in, now I have to make this smaller. We use this approach with the prevalence, the diagnostic impact, and the difficulty to look at the Lighthouse Clinic, what are the important modules that we want to teach? What is really relevant? Okay, we are an HIV clinic, so we have a lot of TB cases. So for us, of course, the prevalence of FASH, you can only do that semi-quantitatively, right? It's rare, it's relatively common, or it's very common. And for us, HIV TB is very common. It has a big impact because if I find it, I can say, give the tablets. And the difficulty, we would say it's moderate, right? And so then you can, in this way, you can rank your modules and say, how important are they and how much time do I want to spend? And here you see we looked at 100 scans, and this is what we found. So for us, the most important is FASH, the ultrasound of the heart, and DVT, and that's usually where we stopped our courses. And then liver, gynecology, and kidney is probably already too much for the first contact with the machine. Good. So, well, what I think, what you see already, that I left out the last three, because I think, and this is something I learned over the time more and more, is less is more. I mean, if you really teach everything, and I remember when I was young and starting this, we went to, I think it was the first time was to Zimbabwe, and we took our German slide sets. And I think the poor guys, I mean, I guess latest when we started with the thyroid, they must have all gone to sleep, but I wouldn't do that today anymore. So, but this idea that I go somewhere and I'm going short, and that's why I want to teach them as much as possible, I think that's probably not the most clever, not the most clever approach. Um, as I said earlier, it's important to think about what is locally relevant, what is locally important. And it's not very helpful to say, okay, this is what I know, so let's teach them, because you often come from a completely different setting. And then yeah, and that's why I think this locally relevant protocols, like I worked a little bit on that, could be work as catalysts. And I want to show you one just for getting the idea. And this was the protocol on cardiac ultrasound in resource limited setting, gets into a curls protocol. So now you have a fashion and a curls. So that's you see it's getting very hairy. It's basically a protocol for patients with shortness of breath, cough, and edema, and possibly an enlarged heart on the chest X-ray if you have a chest X-ray. And this is Grace, where the protocol that we also want, that I worked on with your colleague in Kenya. And so why do we need another cardiac protocol? I mean, the emergency medicine people have blessed us with more than I don't even know how many cardiac protocols, Rush and Fate and whatnot. Why another one? And I think it is a little bit different. Okay, the pericardial effusion is usually always covered, but it has a different, the fact that it comes from TB and KS is maybe different in an African setting. The left ventricular failure is often very advanced. So, I mean, we don't have to think very much on four-chamber view and whatnot. I mean, these patients usually have an ejection fraction of 10% or 15%. So it jumps in your eye. It's usually enough to look at it from the epigastric angle. Cor pulmonale is far more frequent because of untreated or late treated lung disease, in particular TB. And then, of course, we have the post-traumatic mitral valve disease that is far more prevalent than it is in other settings. So what we and the final point was that honestly we found it too hard to teach these 4 echo windows. The epigastric window is nice. It looks like in a textbook for anatomy. All the others, they are just, you need to get your head around why is it looking like that, and why is the left ventricle on the right, or what. So it is I think too complicated. So we use just a single epigastric window, and we put 5 questions. Is there a pericardial effusion? Is the left ventricular function reduced? Is the right ventricle bigger than the left? Then it's cor pulmonale. Is the left atrium bigger than the left ventricle? Then it is rheumatic mitral valve stenosis or disease. And then finally, this is the only one with a measurement. Is the septum thicker than 12 millimeters? Then it is likely hypertrophy. I'll show you just this is just, well, I guess you've seen that all. This is an pericardial effusion. This is due to TB, so you can see the fibrin fibers in that effusion. That's a clear one. So that is this one is enough in the right setting to say, let's give TB treatment. Well, now I would change that today. I would say this is enough. And Jessica said she heard that lecture. I would say check whether there is KS, and if there is no KS, then start TB treatment. This is a patient who is obviously not, the heart is not pumping, and you can, as I said, you can see this doesn't need an ejection fraction. The ejection fraction is a catastrophe, and that means I should not start TB treatment, but I should start. And we have ACE inhibitors. We have, of course, furosemide. We have spironolactone sometimes, so you can create at least some kind of failure regimen for the patient. I think this one is again very obvious, right? The right ventricle is bigger than the left ventricle, so we are looking at a case of cor pulmonale. And then, of course, the question is, usually the reflex would be, is it due to a DVT? Well, that one I can do with the ultrasound, or is it otherwise it's usually a lung disease, and usually very often it comes TB or TB destroyed lung, that as the underlying reason. And then this is the last sample that I want to show you. So you see again the same 4-chamber view, right heart here, left ventricle here, and now of course we're talking about the fluidy part. This is the lumen of the left ventricle, and this is the lumen of the left atrium. And okay, there must be an obstruction in between, and that is then. And I mean, for those who know a little better, can already say, okay, I can see the mitral valve and it's thickened. But that's not the part that we teach. We just say, is the left ventricle bigger or the left atrium bigger? If the left atrium is bigger, then consider it rheumatic heart disease until you have any better idea. That's the article if you wanna read about it again. So for that article, we used the same approach. We said, which cardiac things can we see? What is prevalent? What has impact? And what is difficult? And then we came up with these 5, and that ended up with a 5 in the Curls protocol. Good. Now, Denise asked me to say something on one more topic, and that is on how can we support learning in the long run. And I think there again, I think everybody who traveled or who taught abroad can vouch for that. Consider internet as slow to absent, to almost absent. It's a catastrophe. And that makes uploading clips. And I mean, I know uploading clips is anyway not what people love to do. I mean, because it's work and you have to upload something, and then it doesn't give you much. And particularly if you think if I think of my colleagues at Lighthouse, they don't get any accreditation, recognized certificates, or even better, an increase in salary if they now have the skill to do ultrasound. It doesn't give them anything. If you can do it, it's fine. If you don't, it's also fine. You don't benefit. The only thing where they benefit is when they have a patient on the bed, and then they say, now I want an answer. So, and that's usually when I get approached. So I get, why? Because, well, obviously, A, it's instant learning for the clinician, and B, it's instant change of treatment for the patient. And that's what the clinicians like, because they want to do the right thing. And for me, at the moment, what I see, the only feasible way is mobile instant messaging. And of course, the nice word for WhatsApp, because it's the only thing that is really quick enough and easy enough. So our clinicians do, they film the screen. I tell them please not to film the part with a patient identifier and give me a few words, and they can even use the voice over and say, oh, this is a patient I'm scanning now with a da 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 da, and then you get it and you can quickly reply. And ideally you can do it synchronously. So sometimes they call and say, hey, can we create a video call? And then they show me, and then we do it this way. Or non-synchronous, that they just send you the film and you answer whatever you feel. Good. And now the last thing, and that one is, I don't know, Dan Kamenstein, who's also a very good friend and an emergency physician from Georgia, or Georgia, somewhere Georgia. And with him in our discussions, we came to these 4 steps are kind of important, right? When we do a POCUS or any ultrasound, the image indication. So when should I do the scan? Okay, how do I put the probe? How do I interpret what I see, and how do I apply what I saw to the treatment then? And I think that's a good approach to think about it. And so basically, for the image indication, the patient has lost weight, night sweats, and cough, so I should do an ultrasound, which is not necessarily logic in all settings. I put the probe, I see the anechoic area on the right chest. Fine, that's pretty straightforward. Image interpretation, I think this patient has a pleural effusion. Again, pretty straightforward. And then step number 4 is, I think I should start TB treatment. And that one, I'm not sure how many emergency physicians would say, well, here's a pleural effusion, let's start TB treatment. So, but that is important to remember, that image indication and image application are highly context dependent. And I think if we don't know the context, then it is, I mean, then we should do our best to know the context, and that means you have to work there for a while. I mean, not whatever that while you can afford, but the longer it is, the better it is. Image acquisition is certainly not context dependent. That is something you can learn wherever you are. Image interpretation, probably is also not very context dependent. So it's basically the first and the last that we need to consider. Now I want to make allow me one slide of advert. So we have created, with the Lighthouse guys and these good young colleagues, we have created the CLIP program, the clinical implementation of point of care ultrasound in HIV, TB, and HIV care, hepatitis care in Africa. And so it's basically asking people to come to Lighthouse and stay a couple of, 1 or 2 weeks to learn, to see how they use it. And they're very excited and very keen to show how we use it. And if you want to, I'll put these links in the chat later. This is the link to the website, and here is a video, which is I made my disclaimer about Mindray, but they anyway, it gives you an idea how Lighthouse looks. Good. My conclusion: there is more and more work about point of care ultrasound, but there is not maybe as much work on how should we teach it, and especially it's not so much in high, but even less in low resource settings. When we teach a point, point POCUS, we need to consider carefully what is the context of the learner. Can we really is it useful in that context? And only if it's useful, they will use it. My experience is, if you train them otherwise, and they will be happy to be trained, and then they will do whatever they did before once you're gone. And of course, the long time offsite support needs to be considered, and because it is especially true for image indication and application. And I think that's it. I don't know if I managed 10 minutes. If not, sorry.
No, it was great. Thank you so much, Tom, for all that information. I'm sure people are going to have questions, so we can leave some questions at the end. I want to make sure Jessica has an opportunity to tell us a little bit about where she's working and on her projects, and then we'll go to Grace. And then we have some set questions just to guide the panel discussion on everyone's experience on teaching non-emergency medicine learners POCUS. and the global health setting. So Jessica, if you want to go next.
Great, thanks so much. Let's see, I also am going to try to share a screen here. And thank you so much, Dr. Heller. Oh, let's see. Okay. Because that covered so many things that I also wanted to say, and it was so wonderful. So my focus has been primarily for non-EM trainees, has been in pediatrics. And so I've been working since 2018 in a couple different places, training pediatricians and also clinicians who work in pediatrics. So for instance, this is where I have been working in Mbale, Uganda, and Mbale has senior house officers who essentially are residents, has a few consultants, and then there are clinical officers and medical officers. And as a lot of us know, working in sub-Saharan Africa, there's a lot of medical graduates who don't necessarily specialize. And so the idea of kind of specializing is still a growing field. Emergency medicine actually doesn't exist at this site. So we started the program kind of in a similar way where we did a needs assessment and kind of thought about what were the high yield things that we thought would be useful in pediatrics. And the list of wants of what people wanted to learn was a lot longer than I thought would be feasible to really accomplish in a way that made everybody very comfortable and competent. So we started essentially just with lung and heart ultrasound, and lung ultrasound is extremely easy to learn and is so useful in pediatrics. The heart ultrasound is harder to learn, but actually we published on our training and found that the trainees were just as capable of getting good quality images because we scored on quality in their cardiac views as in their lung views, which I was very impressed with. But in kids, as in adults, a lot of the times there's later presentations of congenital heart disease and other things like that. And so a lot of the times a kid may come in dyspneic with difficulty in breathing, and the etiology is not, in fact, something infectious like a pneumonia, but is more of a cardiac thing. Eventually, over the years, we taught other applications. Oh, actually, we also taught eyeballs right away because we were going to look at optic nerve sheath diameter for cerebral malaria for a research project, but that's kind of a side note. We did teach the FAST and we did teach the FASH, but those were kind of as our learners became more advanced. This is just a recap, and I think most people are familiar with this, but how pneumonia is diagnosed in many parts of the world is just by clinical guidelines. And this is the Integrated Management of Clinical Illness guidelines from the WHO. Essentially, if a kid comes in with a cough, which almost all kids have cough at all times, and then fast breathing, they have pneumonia. And then a severe pneumonia is these danger signs, which include chest indrawing and tachypnea. That's a pretty non-specific thing. So say you have this kid. So say this was a regional referral hospital we were working at. So every once in a while, a kid got an x-ray on the way in. First of all, it's only ever a one view x-ray. We all look at the same x-ray every day on rounds. You guys have been in this situation, right? Where like every day, everybody holds up the same x-ray. It's unchanged. It's obviously an abnormal x-ray, right? And so we're kind of wondering what's going on with the kid. Maybe we even want to repeat the imaging. And this is actually the high dependency unit in Mbale. And they've changed it since this picture was taken. There's now wall oxygen, but you can see that the oxygen setup is extremely complicated for patient transport. So there's no portable chest x-ray. And then there's, two babies to a bed or sometimes three babies to a bed in this high dependency unit. And this thing we call the octopus is how everybody's getting their oxygen. So the oxygen is in large tanks, which are hard to transport, and then it's being spread out to the babies. And so really, not only are babies being diagnosed or children being diagnosed by a clinical diagnosis, but even when there would be an indication or the clinicians would like to repeat imaging, it's really not feasible because there's not any sort of portable x-ray or ability to transport the child safely. And so part of the training was just kind of looking at these different things. And sometimes, unfortunately, we found things like this. So we found babies who were coming in, breathing fast, and they had severely abnormal cardiac architecture, like large VSDs, et cetera. And so that was one of the big kind of ways that we used this, this ultrasound in this setting. As time went on, more and more internal medicine physicians also were interested. And this is Dr. Mutacheki, who was a senior house officer in internal medicine at the time this picture was taken, but he's currently at a district hospital because he graduated. He was extremely interested in cardiac ultrasound. And so I think my role was first introducing the ultrasound to the site, which kind of, I guess, wet his whistle is the way you might say it. And then he went on to do more advanced training, and then also being able to donate supplies, as Dr. Heller said, having a machine is huge. And so we were able to kind of get supplies to the site. He actually started looking for his senior thesis, looking at stroke patients, found that a high percentage of the patients were ischemic stroke, and did a bedside ultrasound on almost on all of those patients. And you can see, like in this clip, huge amounts of cardiomyopathy, a lot from valvular disease, and you can even see the large thrombus in this left ventricle, right? And he just had so many clips of these patients. So I think the other thing Dr. Mutacheki did, which was pretty amazing, is because he got bit by the ultrasound bug and really got good at this, he then was the person that people went to for echo at the hospital. So there was a cardiologist, but there wasn't an echo tech. And the cardiologist obviously was overwhelmed with all the other things. And so he was able to do some pretty comprehensive cardiac echoes, review them with cardiology, and provide patient care, which again is something that, as an ER doctor, that's not how I work, right? I say tamponade, not tamponade. And so this is kind of an evolution beyond the POCUS model. So the other project I've been involved in, I actually just returned last week from 6 months in Rwanda, in Kigali, where I was an African Regional Research Fellow with the Fulbright program. And I worked in pediatrics as well, looking at just a systematic cardiopulmonary ultrasound scan for kids with difficulty in breathing. And so essentially, I enrolled all kids who came in with WHO definition of pneumonia. I was at a district hospital, and so all these kids, it's a decentralized healthcare system, are transferred from their community health center or local health center, or from the OPD, like the outpatient department. And these kids are sick, like a lot of them are on CPAP and things like that. And so my data analysis is still underway, but part of it was just to understand what degree of cardiac abnormalities there are in this patient population who's being treated for pneumonia. And there's actually 2 other studies from other resource-limited settings that show about 10% of kids admitted for pneumonia actually have cardiac abnormalities. So I think it's higher than we think. And then also just to do some explorations into acceptability, talking to parents, asking what they feel about it, and if it's changing clinical practice from the providers. I did training too for the GPs there. And we saw a lot of this, and this was essentially like we saw a lot of kids who have what I would consider more of a bronchiolitis sort of a pattern on their ultrasound, but all of them universally are getting antibiotics. And whether or not it's evolving and whether or not it's the right thing to do, I'm not saying, but I'm saying that of the kids that I enrolled in the study and what we were seeing with ultrasound, we're saying that mismatch between what's being defined as pneumonia with the WHO definition and what we're seeing in real life might be a little different. So this is a project that I'm not personally involved with, but I'm super excited it's ongoing. This is a European African collaborative. It's a 3-country randomized control study. It's in South Africa, Senegal, and maybe Tanzania. I forget the other place. And what they're doing is they're randomizing kids Some of them are going to get lung ultrasound added to their workup, and some of them are going to get standard of care, and then they're going to look at clinical outcomes and antibiotic usage. And I think this is huge because I think that this is going to say, hey, in this environment where we're using the IMCI guidelines, does lung ultrasound, some of us think it really could help, but is it helping, and how is it helping? And so I'm very excited to see what comes out of this group. Finally, to talk about some challenges. A huge challenge is, turns out kids are not little adults. So kids, just are sometimes hard to scan, especially between the ages of 18 months and 2.5. I just wait till they fall asleep. There's like no way you can get at a toddler with a probe. Um, but also just kind of the different views. So for instance, we also included just in our standard POCUS assessment or bedside cardiac assessment, looking for cardiomyopathies, and we looked for VSD, ASD, and PDA. And those are things that I don't normally look for, but were important, as well as valvular pathologies in this patient population. Also, just the approaches, there's a lot more subcostal views with kids and kind of teaching those. And then there were a lot of requests that I had from groups of learners to teach things that I'm not comfortable with, for instance, transcontinental ultrasound. And so what I did is I reached out to colleagues I knew from the American Academy of Pediatrics, actually runs a global health POCUS course, and said, can you just give us a webinar on, this transcontinental or the crashing neonate or some other POCUS protocols that could be really beneficial. And so I think having colleagues that you can outsource to is important. As Dr. Heller mentioned, skill maintenance is huge because, even remembering how to use a machine and all the buttons and all the things is really hard, and you really need to kind of do it daily. And that also brings us to practice integration. For most people, how they trained is they trained that you order an ultrasound and it's like during rounds and it's at a different time, and kind of even creating this whole sort of restructuring and reapproach of saying, what if we integrate this ultrasound into our acute medical decision making and do it right now and interpret it right now? That's a real frame shift. And so kind of having a site adopt this in an integrated practice way is always going to be a challenge. And even here, my emergency medicine residents who have their month-long rotation and are supposed to be experts at POCUS, sometimes it's pulling teeth getting them to use an ultrasound in their acute medical decision making. And so I don't know what the magic bullet is for how to kind of do that frame shift. But I think that that's one of the big key things for how POCUS is going to be the most effective, or how ultrasound is going to be the most effective, is to talk about how we can most successfully integrate it in a way that pays off to the clinician. Like the clinician feels like it was worth it for me to take the time to do this, and that they make a decision that it's going to change management. So, all right, thank you.
Thank you so much for that. That was awesome. So now we'll have Dr. Wanjiku. I'm not sure if you don't have any slides, that's no problem. But if you want to tell us a little bit about your work that you're doing.
Hi. Yeah, I don't have slides. And so mine is just to kind of talk about my experience and maybe try to hit at some of the key points with the 4 questions that you brought up. So I am an emergency physician. I'm Kenyan originally, but I work at Brown University in the US, and I've been teaching point of care ultrasound in Kenya actually since residency. 2014, 2015 is when I started going there when I was a resident. And I started working with, you can hear me okay? Sorry, I didn't ask that. I started working with Emergency Medicine Kenya Foundation. So um, EM was not, a thing. It was not a specialty in Kenya up until 2017. And so back when we were working teaching ultrasound, 2014, 2015, people were like, what is emergency medicine? It was just kind of a frame of reference that, people have no idea what it is. Things are very different now, 10 years down the line. But when I started working with EMKF, we were mostly teaching non-physician, non-EM trained people. So it was a program that was very, we were working in small clinics in the city, in small towns, in rural areas. So these were very, very small, and I think that in Kenya, I'll speak specifically of Kenya, but I think it's the same for, other African countries in the region. Once you step out of the large referral hospitals, in the city, either, the public ones like Kenyatta National Hospital is a big public referral in Nairobi, right? So when you're working there and training there, you're training doctors and you're training specialists. But you step out of that, even in Nairobi, you go to like the slum areas, the clinics there are mostly staffed by nurses and by mid-levels. And so any time that you're teaching there, or if you're teaching in small towns or rural areas, this is the bulk of the healthcare providers. And these are the people that I started working with when I was a resident. And I think that these are the people who inspired me to be on the journey that I am on. And so my experience of them, I admire them. I find them to be just a very inspiring group of people because they're out there, they're trying to take care of hundreds of patients every day, trying to do so much with very little, no imaging. The x-ray breaks down all the time. We know the limitations of x-ray already, right? But even that x-ray machine breaks down all the time. Some of them have ultrasound techs that are only available, during bank hours on the week, so at night, patient comes in, they need an ultrasound. You're faced with the decision of, do I refer them somewhere? Do I keep them? Are they safe to stay here overnight until the ultrasound tech comes in the morning? And over the weekend, forget it. There's no one. The ultrasound tech is not going to come in. And so the limitations are really, really dire out there. I mean, we talk about resource limitations, but I think there are levels to resource limitation. There are some places which are really isolated, just very deprived. And so I think this is where I think point of care ultrasound makes a difference everywhere, right? Even at Brown University when I'm working there. But in some of these places, I find that it really is the only thing that they have. And so I think that this brings up, the challenges and the opportunities too. So I've been working with Emergency Medicine Kenya Foundation, and more recently, I started working with a group called the Canadian Point of Care Ultrasound Society. They have an East African outreach, and I can talk more about that later. The challenge comes in because when you're training non-physician, non-EM, or just non-physician healthcare providers, I think that their training, they did not spend as much time, training on anatomy, on physiology, on pathophys as we did. And so there are some things as physicians that we take for granted, right? About the understanding of the body and anatomy and body planes and things like that, that with this other population, we just have to spend a lot more time upfront going over anatomy, going over body planes and how they translate onto the screen when you're doing an ultrasound. Like that stuff. Orientation, like orienting your probe to what is on the screen. Just spend a lot of time on this until it makes sense, because it sounds very basic to us, but it is not basic to everybody. And so what I love, especially with the CPOCUS, the way CPOCUS trains, so this is a Canadian Point of Care Ultrasound Society, the way they are training, especially the way they train in East Africa, they use a boot camp method. And this boot camp, first of all, there's a lot of pre-course learning. And so materials that you provide ahead of time, reading material, videos, it's a lot. It actually is a lot. And so you're not, and it's going to nurses and mid-levels, clinical officers. It's not, it's the rare doctor that is part of this training program. And so you are treating them as if they do have the capacity. It's not like you're babying them and saying that they're not capable of understanding this. They are healthcare providers. They do a lot. They are capable of doing all this work. But then it's like giving them the time and the explanations and breaking it down. And then when it comes to the boot camp itself, it takes a week. And it's basically just a very deconstructed way of image acquisition. And it starts with the machine. Approach the machine, turn the machine on. When you turn it on, adjust your depth to this. Dive your depth. That's how the Canadians teach it. Dive your depth always. When you get to the machine, dive your depth first. Hold the probe like this, like they teach, like when you're holding the probe, the abdominal probe, hold it, so it takes nothing for granted, right? Approach your machine like this, turn it on, dive your depth, hold your probe like this, put the gel here, and then this is your external landmark. It's a landmark method. So when you approach the patient, when you're doing the subxiphoid, like if you're doing the, let's say you're doing an EFAST, right? So the external landmark is the subxiphoid, the mid-clavicular line. Draw a line from the subxiphoid to the mid-clavicular line, and this is how you hold your probe, and this is where your probe goes. So for every patient, you approach them the same exact way. So it's deconstructed. When you put your probe there, what is your inner landmark? What are you looking to see, right? For the quadrants, you're looking to see the kidneys, or maybe the liver, for the aorta, this is what, so you tell them what the inner landmark is. And then from your inner landmark, what is your area of interest, right? You're looking at that interface between the kidney and the liver, because that's where your free fluid would be. So it's outer landmark, it's inner landmark, it's area of interest for each and every region. And then you drill it because it's a boot camp, right? So you go over and over and over, and they scan, patient, volunteer. We don't scan patients, we do scan volunteers, healthy volunteers. So you do it over and over again. And it's very ABC algorithm, deconstructed way of image acquisition, and it is taught the same. So everyone who learns through this method teaches the same. So it's never going to be, I feel like point of care ultrasound, especially as we expand, different specialists, different people teach it differently. The approach is different. And so when you're teaching people who are, non-physicians, non-EM trained, sometimes it can be confusing. Like, what am I looking for? Where am I going? But that's kind of what I liked about CPOCUS, in that everyone learns the same way, everyone teaches the same way. It's the same approach to image acquisition for everybody. And so at the end of the boot camp, these people who had never held a probe before, come out on this other side, rock star image, they can, obtain images like that. And that's the first step, because once you have the image, then you can teach, then you layer the interpretation on top of that. And then you layer, what do we do about it on top of that? And so I would say that, teaching non-EM, non-physicians, we have to, this is the bulk of our trainees when we are thinking about low and middle income areas, and that kind of breaking it down and making it algorithmic and teaching them the same all the time does work. And then when it comes to clinical practice, also the algorithm too. So what I love about working with Emergency Medicine Kenya Foundation is that they've created these algorithms for emergency care. So they have an app, they have books, little pamphlets that you put in your pocket that teaches you how to approach the patient with shortness of breath. So within that algorithm, this is where the ultrasound goes, right? Because as we know, like from working with nurses in emergency medicine or working with PAs or mid-levels, they work the best when they're given an algorithm of care, right? And so we can place the ultrasound machine within that algorithm as well. This is where your ultrasound goes. This is where you do your ultrasound, and this is what you're looking for. So I guess I don't know what else I wanted to say, but the other thing I just kind of wanted to reinforce what my prior colleague said, Dr. Heller was saying, that there's nothing else, right? The ultrasound is the only thing that is there. And so our trainees really have to be good at it, and that's what I found. And that's what I like about CPOCUS with the boot camp, because at the end, they are rock stars, and they have to be, because that's the only imaging modality, and you are basing your decisions on that. There's no, oh, let me take you to CT to confirm what I have seen. This is it. And so I feel like I'm actually very proud of our trainees in Kenya, because they become really, really good. And they have to, so I'll stop there. I think there's more I could say, but, happy to contribute to the panel, but yeah, and thank you.
Thank you so much. That was great. We we don't have much time left, but we wanted to open up if any of the audience members have any questions for our panelists. If not, Pat has a question to lead us, but does anyone in the audience have any questions for anyone on our panel about teaching non-EM learners POCUS, or any other questions? We'll also look at the chat box to see if anyone sent us anything. Okay.
I can start if you would like, and maybe I can share, if you don't mind. Let me see if I can share my screen. Um, Yeah, so the CPOCUS outreach program, we actually offer a multidisciplinary training. So I took the course myself before I started teaching it. So I had I had done a fellowship first, and I was like, oh, I knew ultrasound, but for me to be part of a trainer with this program, I had to take the course myself so I can kind of understand how it works. But we work with OBs, we work with critical care providers, we work with pediatricians. So we are truly interdisciplinary. And the way we do it, I'm just kind of pulling, it's an accredited course. And so we get accreditation through CPOCUS in Canada. And the course, so the acute care core certification boot camp, I just wanted to pull the curriculum just to see and to explain how it can relate to everybody. So it includes, sorry, the module here, it includes a subxiphoid cardiac, which is very related to what Dr. Heller was talking about. We just do subxiphoid cardiac. Aorta, which is debatable as to whether it should stay there or not, but I think it helps us teach body planes. I find that, it's really good at teaching kind of the transverse body planes and the sagittal body planes. Abdomen is mostly just finding free fluid. So right upper quadrant, left upper quadrant, pelvic, and also it includes a subxiphoid looking for free fluid. We teach first trimester, but we really treat it in a way how to approach the female pelvis. So male pelvis, female pelvis, which is the differences, which is the similarity, what is similar about it. Looking for pleural effusion and pneumothorax. And I find that, like you said, like OBs, of course, have to be really good at the first trimester. There's a separate course for second and third. OBs have to be good at this. But then OBs also receive patients who are pregnant, who are also short of breath, right? And so they have to know how to do cardiac, they have to know how to do lung. Same as pediatricians who come in and they want to be really good at lung. So in East Africa, we've added an additional lung module, a comprehensive lung module to this, and added IVC just because of what people wanted. But I find that, different specialties, to take care of the whole human beings, sometimes people think that, OBs just want to know how to do first, second, and third trimester. But they also have to be good at these other modalities too, to take care of the whole woman, right? Don't want them to think that, my patient who comes in because they're pregnant, I'm just focused on their pregnancy. I'm also focused on why they're short of breath. They could have dilated cardiomyopathy, which is really prevalent. They could have DVTs. They're high risk for these things. And so we're trying to push back against this notion that because you specialize in this, you really only need to know this one thing. I don't know if that answers the question. So we teach interdisciplinary. Some people move faster through things. People who are in emergency medicine, maybe critical care, will move faster through things. But then you kind of leave time for people who need to take more time, because everyone has the same requirements for certification. So if you don't finish in 1 week, you get to come back next week and finish. So, sorry, I don't know if that makes sense. I'm going to stop share. But yeah, absolutely. I believe in interdisciplinary training.
Thanks. I'll add, I've taught many courses that were interdisciplinary, and I agree, especially when you're starting with the basics, because as Grace mentioned, you can never kind of overteach. And so I often start my courses with just, let's touch the machine, let's turn it on. Let's actually like get comfortable and get hands-on. And it's, I think actually interdisciplinary, the other specialists that we often forget about in the US because it's so controversial is the radiologists. The radiologists love coming to these courses. They're able to add, they gain a lot. And that's something that is almost unheard of, in our setting where there's kind of this almost, a little bit of confrontation. So I think that the one thing is every specialist or specialty wants to know why don't use POCUS in their setting. And so as much as I love hiring models for the courses, I also like to do ward rounds too, so that we can bring it home to say, hey, in pediatrics, this is a kid who instead of doing a tap because you think that they have a perineumonic effusion, you could actually look and then not tap this kid who ends up having a dry cap because they never had a perineumonic effusion. So like putting it in a context to say, this is how you use it. And that I think, and that could be going to the ICU, and even the pediatricians can go to the ICU if it's out of their comfort zone, and the ICU docs can go to the pediatric ward. Just seeing how it's integrated into care, I think is very important for everyone, and seeing how other disciplines use it can be interesting as well.
Yeah, maybe I come in as well. But I think you touched you both touched on it very what I would say. I mean, I think like what Jessica said. I think the context. I feel it quite important to do these ward rounds because that's usually the moment when people say, that's why we're doing it. Because then and it's amazing how quickly you end up from we don't have any we don't have any patient who needs it to hey, we can't manage all these patients because they suddenly everybody realizes that there are so many who would benefit from it. And I think that is the one thing which of course needs I mean, this is the moment when you get exposed because that's the moment when you go out and you have to say, okay, this is the thing, now what are we doing? And that is when you need to have good colleagues with you who know the local wisdom, what can be done or what so I think it's very important, but I think it is also something that needs the skill. And what I really like about Grace points, I think this algorithmic approach. I mean, and I taught a lot of clinical officers. So most of my co-workers in Malawi are clinical officers, and I think again, like you said, Grace, we shouldn't make them small because I mean these are the guys who also do cesarean sections. They do. I mean, it's not like they are just little minions who help the clinician carry the I don't know the machine, but they are they can be very skilled and they but like you said, I think they need to know, okay, when I'm doing it, what am I doing, what do I do then? And if it's complex and it has a lot of yeah maybe, and then they will say, oh, this is not for me, this is too complex. So but if you can really break it down, and I think that's where to come back to your question, Patrick, um, to create a curriculum. I mean, it's difficult, I think, because it will depend so much on the setting. So I was recently invited in Zambia, and they said, well, we are interested in liver. We want to find cirrhosis. So this is the goal of our mission. So how do you want to combine that with the obstetrics? In the end, it is something where people need to, and I think people more and more see the benefits and the beauty of ultrasound, but then they need to come up with their questions. So and then you have to adapt to what they need, because obviously if you teach them what you know but not what they need, then it will not be so. Like Jessica said, you then reach out to the pediatricians to tell you how is this brain, how does these brains look? I mean, it's usually not rocket science. If you find somebody who is willing enough to make things simple for you, then it's possible. Yep.
Thank you. Thank you. Well, we're a couple minutes over. Gosh, I wish I had more time with all of you guys. I really appreciate your presentations. This is awesome, and I appreciate everyone's time and expertise. Dr. Schmidt, Dr. Wanjiku, and Dr. Heller for making the time today to join us. I put my email address in the chat box if anyone has any feedback or any questions about today's session. This should be recorded, so we'll be able to post this later. But thank you again for everyone's time, and thank you again for our panelists. We're honored to have all three of you here, and we appreciate you all and your expertise. Thank you very much, everyone. Okay.
Thank you.
Mm.